So now we'll talk about the metabolism. So we talked about sensing. Now what about local metabolism? So metabolism defect is relevant in many scenarios. You can precipitate diabetes insipidus in pregnancy, which I'll talk about. You can have abnormalities in thyroid metabolism and non-thyroidal illness. There could be a problem of metabolism of cortisol to cortisone 11 beta HSG2 defect, which causes apparent mineralocorticoid excess. There could be a problem of 1-alpha hydroxylase, which causes VDDR1, a problem of 24 hydroxylase, which causes hypercalcemia. I'll talk about all that with examples here. And of course, if you have a problem of the metabolism of testosterone to estrogen or testosterone to DHT, you will have DSD. So metabolic defects are also important. In all these scenarios, your hormone is high. The end product is a problem. So again, these all sensing problem, these all problems are different from the synthesis problem in a classical sense. So we know that vasopressin has a very, very short half-life, and within a few minutes, it is degraded from that perspective. Now, often we see that a child with nephrogenic DI, when the mother becomes pregnant, they develop polyuria during pregnancy. Why?
Because the placenta also produces the vasopressin. Produce the DI too.
So why do they don't present in the normal situation?
Because actually they autosomal recessive.
So what is the inheritance of DI, NDI?
It is a X-linked.
So X-linked, so 50% problem is there in the mother. So already the level is 50%, but they are happy. During pregnancy, you have got more vasopressinase. So what they are doing is that they are increasing their vasopressin and trying to compensate. But if this vasopressinase causes a problem, you will develop, your levels will become low, and then you will develop DI. So this is a very peculiar history that X-linked nephrogenic DI, mothers will actually develop polyuria during pregnancy, and that is because of a metabolism in that perspective. So this vasopressinase is, of course, if you give them DDAVP, they will be fine because this is resistant to the vasopressin in that regards. So this is important. Aquaporin defect will be different in that perspective. So where if it is autosomal dominant, then the other person will also be affected. Na? So whomever they are inherited will have complete problem. It is going to have a total problem. If mother has that autosomal dominant, she will develop DI anyway. So that is the different thing. So 24-year-old lady, pregnancy with polyuria, child had nephrogenic DI. This we already discussed, so we will not go much into. Urinary osmolality is low. After AVP, there seems to be a limited response. So this looks like a nephrogenic DI, but this is actually because of the placental vasopressinase. So we need to understand what enzymes can get activated at a different state, and they will make a big difference in that perspective. We all know that the fetal thyroid metabolism is tilted more towards anabolism rather than catabolism. So they don't want to produce too much thyroid. They have more of an inactivating monodeiodinase, increasing the reverse T3, while their actual T3 is low. Now, how is the brain working in that regard is funny. If the thyroid is low and we know that the brain is the major part regulated by thyroid, how is the brain coping here? So that's T4 largely. But because this T4 you are shifting to reverse T3, how is the brain getting the T3? Yes, so that is a major part. So there is a selective increase in the MDI2. So periphery doesn't want any anabolic, catabolic effect. The brain, it is basically working in that perspective, and that becomes important in that scenario. So this is something which becomes important, and this is reflected in the newborn period. So the newborns actually have a state in which your MDI is more towards the inactivation mode, the MDI3, versus the activating mode, and that is why you have this transient hypothyroxemia of the newborn. So 10-day-old boy, period of gestation 29 weeks, phototherapy, ventilation, normal blood glucose, low FT4, and TSH is normal. What do you think, Dr. Vibha? What should you do? No, FT4 is low. So delayed surge means the TSH is falsely low. You're saying the opposite thing actually. So if delayed surge means that you're missing primary, but what I'm trying to say that this FT4 may be actually normal for this age group, the other way around. So he already on dopamine, so all those factors are there, so which you need to be aware of. Better would be to follow up over time in terms of transient hypothyroxemia. So again, metabolism can make a big difference. Now, what are the key changes which happen during a non-thyroidal illness in terms of the enzyme activity?
So in the non-thyroidal illness, we decrease the body to metabolize. So there will be the decrease of the activity of MDI1. There will be the increased activity of MDI3 to reserve, and the brain is getting from MDI2. So there will be the picture like central hypothyroidism. And
so non-thyroidal illness basically is a adverse scenario. Body is going into a shell. It is like a tortoise who is fed with a thread will go inside. So you are conserving, you're not wasting any energy. So as you said, MDI activity, the inactivating will become more, RT3 will go up, T3 will go down. Now MDI2 in the brain, as we were discussing, Dhwani was also saying the same thing, it will go up. That is why the TSH will come down. What else causes the TSH to come down? So one is this brain MDI2 activity. Anything else decreases TSH?
Stress, cortisol.
So cortisol inhibits TSH and interleukins inhibit TSH. So there are multiple mechanisms which may cause that. So you will have low TSH, low T4, low FT4, low T3. So it's classically central. And when you are recovering, it behaves like a primary hypothyroidism. So you need to be very cautious. So the key message is that do not do a thyroid testing during illness unless it's absolutely essential. Do FT4 and TSH and then based upon go forward. So FT4 is low, TSH is low. What will you do here?
The meningitis. So that will be the cause of the non-thyroid illness.
So what should you do in this? Leave it or do something else? So if you have... Okay. Anything else in testing? So as we have said that your FT4 is low because and TSH is low because of maybe effect of the stress hormones, the cortisol, the interleukin. So you can look at one rare possibility that this child actually had a central picture, MPHD. So if you have look at cortisol and if cortisol is high, it excludes MPHD. That is your major concern. If that is high, don't worry. Then forget about it and you can follow up later on in that perspective. So this is a non-thyroid illness and all you have to do is to follow up in that regards. Now, vitamin D, we know metabolism, of course, first 25 hydroxylase, then you have 1 alpha hydroxylase to calcitriol and 24 hydroxylase, which inactivates the vitamin D. Now, out of which these three, which one is least clinically relevant in terms of causing a disease? Why? Even if you have a severe liver disease, you do not develop rickets because you have huge amount of 25 hydroxylase and often you will produce that much in that regards. Now, there is a condition of 25 hydroxylase deficiency also, which causes an unusual scenario in which you don't develop 25 hydroxy vitamin D. So there, what will you find on biochemistry? Your 25 hydroxy D will be low. So you will always think it's more like a nutritional deficiency. So that's a masquerading condition, but that's rare. But of course, if you have a 1 alpha hydroxylase problem, this is VDDI type 1. And if you have a problem in the inactivating enzyme, which is 24 hydroxylase, what will happen? So you will have hypercalcemia. This is known as idiopathic hypercalcemia of infancy. So again, metabolism becomes important. Deficiency of activator will cause deficiency. Deficiency of degrader will cause excess. So deficiency of 24 hydroxylase is causing hypercalcemia. 1 alpha hydroxylase is causing hypocalcemia. Deficiency of 11 beta HSD1 is causing apparent cortisol deficiency. Deficiency of 11 beta HSD2 is causing excess, apparent mineralocorticoid excess. So if you understand what is the activator, inactivator, you will be able to understand what can be the possible causes in that perspective. Talking about thyroid, last time we discussed, can you think of any condition in which you have normal production of thyroid There is no resistance, everything is normal, but still the body is not, body is hypothyroid and you need a huge amount of thyroid hormone replacement. From a metabolism perspective, can you think of a condition? Non-sick child, otherwise stable, but he has severe hypothyroidism. You are trying to give a high dose of thyroid, it is not coming down. What do you think would be the cause? Receptor is normal. There is deficiency. Thyroid hormone levels are not going up. So let's put it this way, TSH is very high. T4 level is normal. T3 is very low.
The T4 to T3 conversion is defective.
Mm-hmm.
That is why we have to.
Or you have got the other thing, you have got excess of MDI3, which is shifting it more towards reverse T3. What will you look at in this channel on examination? Yes. So if you have a large hemangioma or mesenchymal tumors, they may express a lot of deiodinase type 3. And that is why you will cause this consumptive hypothyroidism. So again, if you think of, you will find many conditions which will be associated with metabolic defect in that regards. So 1-alpha hydroxylase causes VDDR2, 24-hydroxylase causes hypercalcemia. So 2-year-old boy rickets, no response to vitamin D. There is hypocalcemia, hypophosphatemia, high ALP. Vitamin D levels are high. What will be your next step, Dr. Manoj?
The vitamin D level is high and it is causing the hypo.
Anything else you would like to do before doing vitamin D here? You will like to ask me about some other result. So hypocalcemia, hypophosphatemia, rickets.
Sir,
Blood gas. So blood gas is normal in this scenario, but we should think of a rare possibility of a RTA, which can also sometimes cause calcium loss. So vitamin D is high. What does it mean? Simple. You have got your hormone, it is either not acting or it is not getting activated. That is what we are talking about. So this is typically, and calcitriol is low. So this is VDDR type 1, which we are talking about. Dr. Vibha, 1-year-old boy who came to you with bone pain, you gave cholecalciferol, and suddenly within the first dose develops abdominal pain and polyuria. Of course, the dose is a bit high. Maybe you needed a lower dose, but still he developed 13.6 at single dose. This calcium is too high. What do you think is the problem?
Might be it's causing hypercalcemia. The vitamin D, it's not being inactivated.
So there is always defense mechanism in the body. If you have got too little vitamin D, your 1-alpha hydroxylase goes up. If you've got too much vitamin D, your 24 hydroxylase goes up. So if you have a 24 hydroxylase deficiency, this is a classical picture. You're developing hypercalcemia because of that. So this is a scenario and your vitamin D levels are also going up. So this is a case of 24 hydroxylase deficiency. All the vitamin D is going towards the calcitriol axis. You don't have that axis is shunted, just like CAH that you will consider. So if you have a child with single dose, low dose vitamin D develops hypercalcemia, this is a possibility to think of. So 25 hydroxylase deficiency will present more like a vitamin D deficiency, nutritional deficiency, you will think of it. Then you have to give a different version of, you have to give 25 or rocaltrol, something like that you can have to give. 1-alpha hydroxylase VDDR, that's of course very classical, and this can cause hypercalcemia from that regards. Now cortisol, we have already discussed, there is an exchange between cortisol, which is the active form, and cortisol, which is the inactive forms. And there are two enzymes, 11-beta-HSD1, which broadly converts cortisol to cortisol, and 11-beta-HSD2, which converts cortisol to cortisone. There are more complexities about 11-beta-HSD at different levels, it does different things, but broadly you can say 11-beta-HSD1 is like calcitriol, is like 1-alpha hydroxylase, and 11-beta-HSD2 is like 24 hydroxylase. Just remember that perspective in that regard. So 1-year-old boy with failure to thrive, Dr. Dhwani, polyuria and hypertension. Potassium is low and there is metabolic alkalosis. So there is hypertension, hypokalemia, metabolic alkalosis. What does it mean basically? There is an excess of aldosterone excess, theoretically. So now what you need to do there is renin is low, but aldo is also low. So this is apparent mineralocorticoid excess. So what are the substances which can act on the mineralocorticoid receptor? So what is the possibility? There is something else which is acting on the mineralocorticoid receptor. The mineralocorticoid receptor is hyperactive, or the sodium chloride channel is hyperactive. So what substances can act at the mineralocorticoid receptor? DOC, so deoxycorticosterone. Then you will have different picture, 11-hydroxylase deficiency. But cortisol can of course act on the mineralocorticoid receptor, and the 11-beta-HSD2 is shielding. So it's like the shield around the mineralocorticoid receptor. All the tissues which are mineralocorticoid responsive, like kidneys, like sweat glands, all those areas, this is actually protecting it. Now, if you have a 11-beta-HSD2 deficiency, you have got a compound which is 1,000 times more in terms of concentration. Cortisol is in terms of microgram. This is more like nanogram, picomole. So that sort of a quantity. So you have just 1,000 times, it will overwhelm the receptor. And that's why it will cause the problem of a scenario. So in this scenario, this is 11-beta-HSD2 and this is apparent mineralocorticoid excess. Now, can you think of any other scenarios in which you don't have a congenital problem in 11-beta-HSD, but there is a apparent 11-beta-HSD2 deficiency? First, can any product, food product cause this? So if you take licorice, it inhibits 11-beta-HSD2. Second, if your cortisol levels are very high, if your cortisol levels normally are 600, they are 1200, 1400, something like that. Child, you are seeing 900, something like that. Your 11-beta-HSD will have a capacity. Okay, if you have got a shield, it can save you from so many people, so many arrows. But if you keep on attacking it, ultimately it will give way. So in ectopic Cushing syndrome, what happens? Cortisol levels are very, very high. So they will overwhelm 11-beta-HSD2, and that causes hypertension, hypokalemic alkalosis. So ectopic Cushing syndrome present more with hypokalemic alkalosis than with classical Cushing's features, because they are very short duration and they've got huge amount of cortisol. So again, this metabolism becomes important from that perspective. Now, androgens, we know testosterone is converted to DHT. So testosterone you can think of as a pro drug. You people say that testosterone also has an action, but it requires 100,000 times more level as compared to DHT to cause androgenization. So that's why it's a pro drug. It is converted via 5-alpha reductase into DHT, which causes external genitalia development, and is converted to estradiol to cause the growth plate, epiphyseal fusion, and all the other effects in that perspective. So if you have a problem in 5-alpha reductase, you of course have what is known as a DSD, XY DSD, and we all know that there is a penis at 9, Shikhandi sort of a syndrome, that sort of a later development of male gender happens in that perspective. Now, why is, Dr. Vibha, that in 5-alpha reductase, your internal structures are normal, but external genitalia are defective?
In the introduced testosterone area, that is sufficient to for the within structures to develop.
So even if you don't have a 5-alpha reductase there, they are so high that they will cause virilization internally. Externally, they get it through the blood. So there the levels are not high enough to cause that. They will be high in two situations, mini puberty and puberty. So this you will see if you have a 5-alpha reductase, they will virilize during maybe mini puberty also, but definitely during puberty, this will happen in that regards. So this is of course the aromatase. So 10-year-old girl with clitoral enlargement, Dr. Dhwani, phallic length is 2.2. And parents say that, okay, earlier there was no development, now the development has started. Bilateral gonads are present, and there is no uterus on ultrasound. Karyotype is XY. So what are you thinking of? Yeah. Who is virilizing during puberty? So what are the conditions which virilize in puberty? DSD, which virilize in puberty. 5-alpha reductase deficiency. Second, Dr. Manoj, partial AIS and 17 beta. So if you have, so what I'm trying to say that if you have a partial defect, if you have a complete defect, that is different. If you have complete AIS, nothing is going to happen. If you have a complete 17 beta HSD defect, this will be complete female. But if you have a partial effect, 1% is being produced. Now your levels become so many times, 10 times, that 1% becomes 10%, 20%. So that is why you have virilization. So three major conditions which virilize in puberty are 5-alpha reductase. Because your 5-alpha doesn't do more, your testo becomes very high. And it can have a direct effect on the gonad. But that is insufficient to cause enough virilization as male will develop. Partial AIS, because then your androgen levels will go up and the receptor at a higher level it will start acting. And then finally, as discussed, 17 beta HSG, you will have more production in that regard. So this again is a problem of metabolism that we are talking about in that perspective. Day 3 child with DSD, Dr. Manoj, Prader 4, no palpable gonads. I think this is the case you're going to present also this Saturday. XX karyotype, 17-OHP was borderline, diagnosed as CAH, started on hydrocortisone, which was gradually stopped, and now off steroids, 17-OHP levels were normal. So this was labeled as CAH, but was not CAH, now presenting later in life with delayed puberty. So what are you thinking of?
Sir, at the Prader stage 4 was there, and this is XX. So this is excess DSD in which 17 hydroxylase is normal. So now the aromatase will become in the picture.
So there are two things. You have androgen excess and you have estrogen deficiency. If you combine the two, you've got two diagnoses. One is aromatase, second is POR defect. That effect also affects the aromatase. So you are basically, so you can have 17 OHP or 25. 21, you will not have that low 17 OHP. So that's why it may be POR, because POR will have mild elevation of 17 OHP may actually happen. So POR is very likely in this case. But again, if you simply say your androgen is high, your estrogen is low, it means androgen is not getting converted to estrogen. This is an aromatase defect classically, which you will see. If you have a estrogen receptor defect, your estrogen will also be high. Estrogen will be high, androgen will be high. So that is a different scenario.